through the text messaging and tweets, and we can also take direct questions from the audience, but if I can perhaps cover a few of these first. So there were a couple of questions about paying for the fourth-year skills course, and I can tell you what we've done at our institution. What really allowed us to get this jump-started was the seed grant money from the School for Innovations in Medical Student Education. We currently, that allowed us to develop some of the initial capital expenses for some of the simulation items and that sort of thing to get the course jump-started. The faculty aren't paid anything. It's all volunteer. It's a fair bit of time and effort, particularly on the part of the course director. And we have support through our simulation center, which also helps. Having said that, we currently have about $300 a year per student in capital outlays that are required from some of the materials and that sort of thing. We also have been successful in getting some grant money through industry for supporting some of the specific training sessions and that sort of thing. So it's a little bit of a hodgepodge of different types of funding. You can do this relatively inexpensively, and I think that the return on investment for something on the order of probably $5,000 to $10,000 a year to train 20 students to get them ready for internship is a pretty small investment, really, for potentially huge return. Yeah, let's take a question from the floor. Yeah, Mike, Dr. Holtzman.
Quick question. CMS, Dr. Sajid referred to it, but GME funding very well could be cut in the coming years from CMS. What happens to ACGME there and the carrot they hold over our head with these regulations? And where do we go if they cut funding?
There has been a lot of dialogue through our Washington office about this, and we do anticipate that the funding will get cut. In fact, it's not whether, it's how much. And the numbers we have seen floated are 20% of the indirects. There has been no talk, to my knowledge, about cutting the direct component. As I'm sure many of you are aware, the indirect is the bulk of it. It's about $7 billion a year. The direct is about $2.5 billion. So it's out of the $7 billion that goes to the hospitals and teaching institutions and so on. That's the one that is being targeted. I have no doubt that it's going to impact our GME functioning very dramatically. We are keeping tabs on some of the options that we might look at. And the ACGME is very concerned because, yes, it will impact the functions of the ACGME very directly, because one of the big sticks they have is the Medicare funding to keep people within the ACGME fold. So that's going to be a major issue for everyone to tackle.
Can I make a comment? Yeah. But I think it allows us proactively to look at this. I mean, we can just sit back and wait for this, or we can say, the funding's going to drop. How do we think we should train people? And look at it really as an education issue, not just purely as the government's telling us issue. And there's good and bad points to the ACGME, and I you know, obviously am not in the right venue to talk about negatively about the ACGME, but there are advantages to not being ACGME accredited fellowships, as the GI ones are not, and we're not really interested in becoming ACGME accredited because you lose that autonomy piece, which is probably the important educational piece, and also those people can bill for things that they're not in their training for. So it's not absolutely clear-cut that our whole goal should be maintaining the ACGME as it is right now. We need to really think creatively about this, and if we're only going to get a certain amount of, we're going to lose 20% of our funding, do we cut every resident's salary by 20%, or do we cut a year out of the residency program as it is?
There was a question submitted that said, is there any consideration of withdrawing from the ACGME? Dr. Britt?
Consideration of what?
Withdrawing from the ACGME, looking at another.
Well, I want to tell you, like President Obama, that's not taken off the table. I mean, at the end of the day, the ACGME, if for some reason, I'm not blaming ACGME, but let's say that we're turning out a poor product, we would have to consider another option as far as accreditation. And again, it's not unheard of. As I mentioned in my talk, the Royal College of Surgeons of England, I'm not sure about Canada, but a lot of the Royal Colleges do it all. They certify, they accredit, and they educate. And we may have to look at that model. So to answer your question, no, that's an option.
Question from the floor.
Kosinski from Medical College of Wisconsin. There's so many interesting things we could talk about, but I wanted to back up to the medical student experience some. and the proposal that we might need to find ways to prepare people better, but it seems to me that there's lots of opportunity and not much taking advantage of it. The thought that somebody would not have seen a patient crash on the floor until they get into their internship is hard to reckon with when you have, and then we see that you have less than one call night a month. As I'm dealing with students and with interns, there's an increased expectation of being able to have a say in how things are done, and yet an estrangement from a sense of accountability for what you're learning and doing, so that if I even ask a medical student, can you write this prescription for Percocet, they'll ask me for the dose and things, even though they've got an iPad in their pocket and a book. They have all the resources there to look that up themselves, and I'm not sure how we're going to make that connect.
See, this milestone initiative, in my opinion, should be on the front end, and it should go into the medical school curriculum, the 4th year. You know, obviously we're talking about milestone, the final phase with MOC, but let's go on the front end. The front end should also include milestones that medical students should meet. We know now that medical students are not as prepared coming out their 4th year. That 4th year is a wasted year, in my opinion, for the most part.
But is this really a lack of educational opportunity, or is this a lack of somehow connection with what you're going to be accountable for? I mean, I remember being afraid that I was going to have to give a drug dose for something as an intern, and that you needed to be able to make those decisions and do that quickly. And if for no other reason than being afraid of the responsibility that I was assuming, there was some motivation to do that, and that link seems to be missing.
In my opinion, I don't think we have an accepted standard curriculum for the 4th year of medical school that we need to have.
I think one of the things that really stands out is that in many institutions, the 4th year, what the students do, in the old days, the sub-internship, you were really acting like an intern, and for a variety of reasons, that type of sub-internship doesn't exist as commonly anymore, and students, with the change in the way call is structured to predominantly night float type systems, medical schools haven't adapted to enroll students into those types of programs. So I think it's going to take some fundamental restructuring in the 4th year to address a lot of these issues that you're talking about. Dr. Stain.
What I've seen from the next accreditation system actually scares me. For trying to do rotation-specific evaluations for a resident for all the 6 domains of competencies is an incredible amount of work for the faculty and the program director. I think what John suggested with measurable outcomes like completing ATLS, completing FLS are much more doable, and if we included things what Dr. Sachdeva talked about, some of the module-based programs on professionalism, ethics, we could probably meet those domains without having to have a program director have to evaluate 8 residents every 3 months, and I don't know if we can push back to the ACGME about how their definition of the next accreditation systems is evolving.
Yeah, I think in my mind, the milestones are most useful for the cognitive assessment and for patient care and technical skills, where there are tangible things you can measure and you can move forward with. You're absolutely right, Dr. Stain, that in terms of the other 4 competencies, we ought to seriously consider looking at people completing a course. Even the slide that Dr. Britt showed, which is from the New England Journal of Medicine, where it's divided into 5 columns and 5 levels, it's very hard to distinguish those kinds of things and to really put the dot in the right box or a check in the right box for across those areas. I'm not directly involved with the Milestones project. It's been primarily a work of the Board of Surgery and the RRC, and maybe Dr. Marby might want to address that.
Or, do you want to talk about it?
Or Dr. Hunter.
No, I can just talk about it briefly to say that I think there's still a lot of work to be done. I've been talking to Frank Lewis as recently as last week about this, and I think that there's concern at the American Board of Surgery that this article was published with not quite enough forewarning. And so I think and I think Dr. Stain has echoed some of the concerns around the requirements as proposed by Dr. Naska. So I don't have anything more concrete to say about it, except that it will clearly bring the focus of the board back to the creation of milestones and how we deal with this.
Yeah.
We have just a few more minutes. minutes, and there are a number of things tweeted in here, and I'm afraid we're not going to get to everything tweeted in, but there are two that I think really sort of beg to be answered, and probably the others do as well. But the first is, and this is just for the panel, I'd let anyone take this on. What has been the impact of increased use of inpatient physician extenders on student and intern readiness for independent patient care, and how do we counter these effects? So the question is really, have physician extenders detracted from our experience? Dr. Nada, maybe you should take that one.
Thank you very much. We've actually tried to deal with this as the resident hours have impacted on the intern's ability to stay in the hospital. We now find that the only way we can satisfy the mandate for a 16-hour workday is to just not have the intern on call at all, which is, again, a very different experience than most of us in the room had. It's interesting that we have PAs on the specialty services of orthopedics and neurosurgery and that sort of thing, and they function in that capacity as the medical doctor for the orthopod or the neurosurgeon or the urologist. When they're on a general surgical service, they have a much more subservient role because there's a resident program existing with them, and it's not a very satisfying experience for them, and it's not a very ownership-based model for the intern. It's very easy for the intern to develop a list of things he wants the PA to do, less compelling for him to get them done himself.
I just hope we're not developing, and I got to say this, I'm not speaking for American Surgical, not speaking for the college. I just hope we're not developing a Ponzi scheme in surgical training, where you have a lot of great promises, because to date, we really have not seen the outcomes. We have not seen improved outcomes with patient care. You look at some of the metrics I've looked at that for the board, the CE, according to Dr. Frank Lewis, we have a 50% increase in the failure rate. So we're having all these metrics that are not showing an improvement, and we keep saying that the promises are there. To me, this is a Ponzi scheme in training unless we get some outcomes. I don't mind drinking the Kool-Aid, but you have to show me some outcomes. I have not seen it. And again, I'm not speaking for any organization. I'm concerned about this.
There's a question from the floor.
Let's just take, it's really,
Let's do a couple more of these, and then if we have time,
yeah,
we'll get back.
it's already noon, so we got to break up pretty soon. But there's one I think that really begs, it's more of a comment than anything, but I think that we up here should address the comment. It says, resist subdividing general surgery. So this most reflects an ivory tower, multiply subdivided practice, reflected in the tendencies of graduates to punt rather than address problems in private practice. And goes on to say, it sort of suggests that there will only be people who treat the left great toe or right upper lobe pneumonia when they leave training, and is just the way ivory tower medicine is practiced. And I'm going to take that on first, because I think it's maybe provoked provoked something where I think that there's often the assumption that the word ivory tower is used often in a derogatory way towards academe, as though what people in the universities are trying to do is preserve the way that medicine, or only teach the way medicine is practiced in the university. And I think that most of us who are responsible for university general surgery training programs realize that our responsibility lies a whole lot greater and a whole lot deeper than just training people to be uber specialists. And I think community-based programs that are affiliated with university programs, community-based training programs that stand on their own are critically important. And what I've said at the Board of Surgery is that it's very important to get it right for general surgery first. And there's now a task force on general surgery at the board to really try to get the training right for general surgery first. Once you do that, I think then you can build out what specialty training ought to look like.
Can I make a comment?
Absolutely.
Two things. If you look at colorectal surgeons that are board certified in colorectal surgery, the bulk of their practice is actually not colorectal surgery, it's general surgery. So the ivory tower piece doesn't really work. And I think my second comment is you've got to sort of figure out what's the core of general surgery, because if you train people and they finish training in general surgery and they're not competent to deal with the acute abdomen or some general surgery thing, and then they go to a fellowship, obviously they can't do it. So we need to do something to figure out what the absolute core of general surgery is. I don't think we're disagreeing, but even most hepatobiliary surgeons take general surgery call and are able to take care of these patients. So the fact that people do fellowships is not really necessarily a response to anything, but they don't feel like they're completely trained when they finish general surgery. And most of our residents that leave our program go off and do some type of GI surgery, MIS or colorectal, but their job ends up being general surgery, and I think they're great general surgeons after doing that fellowship training.
Let's have one last question from the floor.
Thank you to the panel for your time and your talks. As a general surgery resident myself currently, I think that training in this era of changing patterns, I still have found that the most educational and most valuable aspect of my training has been to take a patient from the emergency room to the operating room to the ICU with post-operative care and managing every step in between. In doing so, when there are duty hour violations and issues as such, how would you, as an ethical issue, how would you recommend that we, report our duty hours or deal with the duty hour restrictions in this setting?
Well, you do have some exceptions. I mean, RRC, if you have a special case and you have to do exactly what you just said, go through the continuum, that's fine, because there are, for exceptional cases, you can do that. You just can't do it consistently.
But I think that as a general surgeon, our training demands that kind of responsibility on a consistent basis, at least more than 50% of the time, to do a good job in our work. Is there something that we can do?
So you're talking about continuity of care?
Correct, sir.
Dr. Nada.
Dr. Britt and I have gone round and round about surgical training and the acute care surgery model, but the thing that we agree upon is that the acute care surgical model is what the general surgeon used to be and what you're describing. You know, the thing that's a little bit distressing is that the program directors and the acute care surgeons are not a little bit more closely aligned than they currently are, because they share very common goals, and it might be that it's a prudent thing to have the evolution of things go in the direction that the program directors are in fact the acute care surgeons, because that's sort of where you're coming from in terms of your continuity of care piece.
Yeah, I think this is an interesting piece, and we're not going to solve it here, but there is a sort of a cultural divide beginning, and most people who run acute care surgery programs, and someone might take my head off right now, really are those who come from a background of trauma critical care with a team-based model. Now, team-based care is wonderful, but it's not what you're talking about. And many people going into general surgery still want that model with individual accountability, individual care. Now, there is some value and there is some importance in learning the communication piece of sign out, of turning your care over. You're here at SAGES. Someone's taking care of your patients. How well did you sign out? How well did you provide the information they needed to care for your patient when you were here? So we got to do, I think we have both. We got to train people to do both.
Well,
like to go
our time, yes, thank you.
I'd like to go on record as saying I'd let David Mowry take out my colon. But in seriousness, we deal with an IPA in our system, and the IPA is often after me to say, who's your melanoma guy? Well, it depends what you're asking. If you're asking who's my deep groin dissection guy, that might be somebody where I'd have a short list for. But if you're asking who has the basic skills to diagnose, treat, initiate the care for routine melanoma, that's a different question, and that's somebody with broad-based general surgical training and somebody who we should be able to turn out in a 5-year program.
Dr. Britt.
Well, we have to accept there are two casualties to all this transformation in education and surgery, in my opinion. The first casualty is continuity of care. As we know it, is gone. The second casualty is obviously teaching. We don't have the same sort of time for residents to teach students and attendings to teach residents. Those are two casualties I got to tell you I have already accepted.
And with that, our time for this session is up. I'd like to thank all of the speakers for their contributions and thank you for your participation.